Another test that helps us with the diagnosis of multiple sclerosis is a spinal tap, where you remove fluid from around the spinal cord and analyze it. And what we look for in the spinal fluid is the presence of certain proteins that we call bands. Actually, the proteins are run out on a gel, and these certain proteins appear as these band-like strips, and we want to see those bands in the spinal fluid but not in the serum. These proteins are substances that are produced by inflammatory cells in the central nervous system, and we see them in multiple sclerosis. You could also see them with other inflammatory conditions of the central nervous system. For example, sometimes lupus affects the brain, and we can see these bands. Certain infections like Lyme's disease could result in these bands, but they're most common in multiple sclerosis. The test is helpful, but once again, it doesn't indicate with 100% certainty whether or not someone has MS, not only because other conditions could lead to the development of these bands, but because up to 30% of patients with MS at the beginning do not have the bands. In most studies, approximately 80% of patients will eventually develop them. But if you do not have this finding in the spinal fluid, it doesn't rule out multiple sclerosis. So now I'm going to talk about the different types of MS. And for decades, we have been categorizing patients into different subsets based on their clinical course, the history of their symptoms. As I mentioned earlier, the relapsing remitting form is the most common form. 85% of cases of MS start this way. And what this means is on these graphs, we're measuring disability or neurological symptoms over time. So these bumps represent episodes when patients have MS relapses or exacerbations, as we call them, in which they develop new symptoms. The symptoms I reviewed earlier, it could be optic neuritis or decreased vision in the eye. It could be a spinal cord syndrome where there's numbness and weakness below the waist. Early on, though, most patients tend to recover, often back to baseline, not always, but they tend to improve. But if this is multiple sclerosis, they will inevitably have another attack. And the time between the attacks could vary between 3 months and 30 years. It's quite variable. But over time, more and more attacks will occur. Now, in some patients, over time, the relapsing remitting phase of MS changes and evolves into what we call secondary progressive MS. And by progressive MS, what we mean is that someone has a certain group of symptoms that slowly get worse over time. Often this takes the form of weakness on one side of the body or labored gait, sometimes memory problems, but it doesn't occur as a discrete episode like we see in the relapsing remitting stage. These symptoms just very slowly and gradually get worse. So you could see someone, for example, who may be limping because of an MS lesion, and when you ask them when that started, it's hard for them to recall because it happened very gradually. They know that they're not walking as well today as they did 6 months ago or a year ago, but the time frame is less clear. So that's what we call secondary progressive MS, and it follows the relapsing remitting phase. It's secondary because it occurs afterwards, or secondary to the relapses. There is a rarer form of multiple sclerosis called primary progressive. This accounts for about 10 to 15% of cases of MS when an individual will not have any relapses but will just go into a progressive phase from the get-go. And there's a lot of debate over whether primary progressive MS is actually a different disease from relapsing remitting / secondary progressive MS. So here's another illustration of the clinical course of relapsing remitting MS over time. Just as I showed you before, these bumps represent attacks of multiple sclerosis when patients develop symptoms. In between the symptoms early on, they may return to baseline, but inevitably will have more attacks, and some patients will at some point go into this progressive phase. So this is a timeline. Now this graph also illustrates a point that I'd like to make regarding the phenomenon of silent lesions or plaques. These arrows are meant to represent the appearance of new lesions on MRI scans, and you could see that they outnumber the actual attacks of symptoms. So it turns out that the majority of plaques don't cause symptoms when they're forming. In fact, 10 times or more plaques are what we call silent as opposed to symptomatic. Why is that the case? Well, the plaques in multiple sclerosis aren't as large as, for example, a big stroke. They're relatively small, and often if some nerve fibers are damaged, other nerve fibers can take over the job and compensate. Also, a lot of the lesions can form in areas of the brain that have to do with intellectual functions, ability to calculate, personality features, and a small lesion is not going to be evident to a patient or his or her family or coworkers. So many lesions are forming sometimes when people feel fine, and that's why we regularly do MRI scans, even if a person believes that they're stable, because as these silent lesions collect and accumulate over time, there's less healthy nerve fibers to compensate, and ultimately patients could enter a progressive phase. I've had patients who, this is not typical, but I've had several patients who've had an episode of optic neuritis as a teenager, for example, did not have another attack for 20, even 30 years, and then entered the progressive phase, because by chance all of those plaques that were forming were in areas that didn't cause symptoms, but then they built up over time and led to progression. So the MRI scan allows us to get a more accurate idea of what's going on with the disease in individual patients. I mentioned primary progressive MS. This is the type of MS where an individual slowly accumulates disability over time without having relapses. This form of MS tends to present later in life, often between the ages of 40 and 50, as opposed to the relapsing remitting phase, which occurs in the 20s and 30s most typically. Also, in this form of MS, men are affected equally to women, as opposed to the relapsing remitting form, in which there's a twofold higher incidence among women. And there's less evidence of inflammation on MRI scans in this form of the disease. They don't have as many of those plaques that take up the dye, which indicate inflammation. So some people think this is a different form of disease that doesn't involve so much inflammation, that involves more of a dying back of nerve fibers with little inflammation. A number of scientists who are my colleagues and experts in MRIs actually believe that it is indeed the same disease. There's just a spectrum with regard to how it presents. And sometimes within the same family, we see individuals who have relapsing remitting and who have progressive MS. And there are new gene studies that are coming out that were just published, in fact, over the last month. These are studies in which hundreds of thousands of patients have been analyzed to look for genes that increase your risk of MS. And it turns out that the same genes that increase your risk of relapsing remitting overlap with the genes that increase your risk of primary progressive. So I'm beginning to think that they really are, relapsing remitting and primary progressive disease are really the same entity, but at different ends of the spectrum. This slide shows a series of MRI scans done on one patient over 6 months, and the MRI scans were taken a month apart, so there are 6 scans. And the scans were taken so that normally you cannot see the lesions very well, but if you inject the dye, they light up. So this just shows you how this person has lesions which are coming and going over the course of the 6 months, and actually he didn't have any symptoms during this time period. So once again, to illustrate the point that you can have these silent lesions develop.